No, Giovanni Gorgonni. Good afternoon, everyone, and thanks. Okay. Thanks for inviting us to show a project of ours on e-health. I start with a short overview of who we are as Apulia region. Apulia region is a region of southern Italy. If you have an idea of Italy's shape, it is the hill of the long boot. So we have 4 million people, citizens, and we have an annual expenditure for healthcare of 7 billion euro. Shortly, you can see our offer system very shortly. 6 local health authorities, 2 research hospitals, 2 university hospitals, 33 private hospitals, 500 private social providers. So in terms of hospital beds, we have 13,000 beds among public hospitals and private hospitals. And it is a region increasingly aging. As you can see, the age pyramid from it doesn't work. From 2002 till 2016 is increasingly overturning. And above all, 4 citizens out of 10 are chronic patients and expend 86% of annual healthcare expenditure. And 1.5 citizens out of 10 is a severe chronic patient. 17% more than Italian average. Chronic disease is another southern question, another southern issue, because its incidence and prevalence is bigger among poor neighborhoods, poor cities, and so on. So a region increasingly aging and chronically living. Who we are, Apulia region and its health agency. I am the chief executive officer of agency, and Apulia chose an ambidextrous model to improve and manage health and social issue. AreSS Puglia for exploration and Dipartimento Salute for exploitation. So we manage the lab, and our colleague from the department manage the factory. Exploration and exploitation. Our vertical function are for AreSS Puglia: epidemiology and care intelligence, health technology assessment and research, system innovation and quality, e-health. How did everything start? From the hospital. We had 2 hospital reforms in 2010 and 2016. Before 2010, we had almost 100 hospitals between public ones and private ones. And after 2016, we have 60 almost hospitals and 13,000 beds, starting from initial more than 15,000 beds before 2010. And these reforms gave us an opportunity, a chance for an evolution for the system, and the chance to design a 3-stage continuum of care. The hospital network, the new hospital network, a 3 tiers hospital network that's articulated on a basic hospital, a first level hospital, and second level hospital with complexity increasing and a wider population area served. Community care center in the middle, and Care Puglia 3.0, that's our regional chronic care model. Pay attention to community care centers, because we consider them the bridge for intermediate care. Too heavy. Okay. That's not important. What I want to remark is that what once was a hospital before 2010 now are a community care center. We call them PTA, Presidio Territoriale di Assistenza. So we didn't lose those facilities. We transform. We didn't shut down hospitals. We transformed them in some useful, with 10 service areas, no more hospital, never simple ambulatory, 10 service areas, and 5 care places. Maybe you know this chronic care pyramid. From the base with patient exposed to risk to do age with terminal stages, our community care centers include those places, those care places covered by blue cell. The bridge. Let's go with the experience. This experience is one of our e-health experience born and run into the framework of European Innovation Partnership for Healthy Aging. Puglia is from the last September a reference site, a 4 stars reference site for healthy aging with Lombardy region in Italy and with the University Federico II in Naples. TELEHOMECARE is maybe the experience most promising in terms of scaling up possibilities. But we have also the project of teledialysis, the experience nowadays of telecardiology, the emotion project for hemophilia patients, and hematology, and the project Smart Health for hematological patients at home. TELEHOMECARE, a brief description. TELEHOMECARE use a new technology called Hospital at Home, developed by an Apulian startup through regional intervention for industrial development. The system is allocated at the patient home, but it has a central control room at the community care center of Ceglie Messapica. One community care center out of the existing 31 Apulian community care centers. Through the system, GPE, specialist physicians can see the patient and talk to your healthcare professional, and it is also possible to deliver therapy. What were our objectives in 2015 when the project started? First, reduce the number of patients with heart disease, chronic diseases, and diabetes. Reduce hospitalization, activate the protected the hospitalization, optimize therapy, promote the integrated care management. And that is our most challenging objective. No, not those technological that also bring some challenges, but the most challenging issue was the organizational, professional, and cultural integration among GPE, among specialists, among nurses, and among nurses in the role of care manager, and among regional system. Evaluate the satisfaction of the doctor, caregiver, and patient. The patient. At the pilot stage 2016, 2015, and 2017, 300 frail patients, and I mean with the frail patient, I mean those patients discharged from the hospitals and who doesn't have or who have a low self-sufficiency, so they cannot stay at home without support, without medical or care support. 300 frail patients with those chronic disease, COPD, heart failure, and diabetes, and among them, among half have comorbidity. The device is this one. We have two kind of device. This is the wheeled device for patient home, but we have also a laptop version without air concentrator and without endocavitary absorption. The device: blood pressure, ECG, body temperature, heart rate, respiratory rate, saturation, video communication module, oxygen administration and concentrator, and endocavitary aspiration. At the pilot stage, in the local health authority of Brindisi at Community Care Center of Ceglie Messapica, they used 11 wheeled devices. And the system was this. On the left, the first care place, the Community Care Center. At the center, the second care place. And on the right, the third care place. Community care center, patient home, and primary care practice. The results after the first stage, 3 years. Reduction of hospitalization, patient satisfaction, enhancement of out-of-hospital support, patient self-sufficiency, and cost reduction. I guess that the most important results are patient satisfaction. 81% of patients were very much satisfied patient. The other one, most important reason, is reduction of hospitalization. 38% less hospital admissions. I don't know which is the hospital beds ratio in Scotland. Italy has an hospital beds ratio lower than European average. we have an hospital beds ratio of 3.5 beds for 1,000 population. And Apulia has a more ratio with 3.1 beds for 1,000 people. So reduction of hospitalization is very important for us to provide alternative care setting for frail patients, and important also cost reduction. For the first 3 years, the reduction estimated was almost of 250,000 euro from avoided hospitalization. But pay attention, because this estimated cost is based on DRG's price, and DRGs are not real representation of cost. So we can say that we had at least 250,000 cost reduction. Scaling up in progress. The first stage from 11 devices and 300 patients. 2, and and that's current stage. 152 devices among 56 wheeled and 96 laptops for estimated 3,000 patients to be recruited. And the third stage, regarding the agency, a call to make system of these local experiences, a regional HTA in progress to scale up experience at regional extent. How? Through PPI tender, because we guess that we couldn't provide efficient, complete and integrated solution with in-house building and providing, and the real value-based solution could come through a private, public-private partnership. Okay. Closing suggestion. Telemonitoring activity can bring benefits only if it is included in a managed model. No gadgets. Yes system. The strong collaboration between specialists and GPs is very important. And I said it was the most important, the most challenging issue. The patient recruited in telemedicine program must receive correct information, because the patient is a provider too, not only a receiver of care. Fourth bullet, intervention must be personalized and not implemented according to region assistance model. That's all. Thanks.
Thank you very much, Giovanni. Are there any questions with respect to this topic?
You were talking about how the collab.
Yeah, right, that's good.
You were talking about how challenging the collaboration was between the specialists and the GP. Why was that? What were the key issues?
Only for a cultural dimension, because specialists guess that chronic patient is his own property, because has a specific disease, and because GPs are yet a physician for generic purpose, for overall purpose. So lack of culture from specialists and lack of culture from GPs. That's 3 years ago, but with this experience and more again with the Care Puglia 3.0, that is our flagship on integrated care initiative, something more is changing from cultural and professional point of view.
Are there more questions?
Thank you, Janet. Here we see, from a technology point of view, we see a completely different approach of bringing a device at home. You have seen a very integrated device where all the different components are there, and I guess that is one communication channel that sends all the data in an integrated way to the electronic health records of the hospital. We have seen in NWE-Chance, we have a completely different approach where we take a number of different modules, components, and then we integrate them on the bed of the patient, on the sofa of the patient, through barcodes and identification mechanism, and then through different portals then in the back end. The integration takes more in the back end. So these are two very different approaches. How do you see the argument of NWE-Chance is to have an open system where we will be able to integrate devices and technologies from other suppliers. How do you see integration, and how do you see the development of the device to care or to take care of other patients or for the diseases?
Okay, for TELEHOMECARE, we hadn't integration system, integration issues, because the system was born natively integrated. Mm-hmm. And that's good for specific cluster of patients, frail patients, or hemophilia patients, hematological patients, or nephrological patients for teledialysis. When you go on a wider system, such as chronic Care Puglia 3.0 for all chronic patients with every risk levels, I think you need to have a stable, integrated core technological and organizational model. A narrow but a core model with the possibilities to integrate devices, softwares, and so on. For Care Puglia 3.0, we have a narrow, a tight technological core model from regional backend, and we leave the GPs free to to search and find his own software solution, path providing solution, but they have to provide data in the form we need, with the frequency and with the pace we need, and so on. The GPs asked us to have their own system for primary care practice, home devices, the software to manage the clinical pathway, the reminder system, and so on. Managing a so wider system from regional part, it would be very tremendous as a challenge, and above all, I think we could not have the most efficient tender to acquire a complete system. for many reasons, because our public tenders code is not so receiving European directive on PPP or on value-based service tenders.
Are there more questions?